So I'm going to start off with imaging the shoulder, X-ray, and beyond, and just talking a little bit about some of the techniques that we use. And when I asked Christine what I should focus on, and she said a question that often comes up is, is ultrasound worth adding to a practice? And so I'm going to talk a little bit about that in terms of things that would be helpful and they sound good, but then, other concerns that people might have so that you can help weigh. And the first thing is that ultrasound is actually similar to MRI or MRA for evaluating full thickness rotator cuff tears. And that's really the information that surgeons need. This is a paper from 2009 in AJR, and it looked at the accuracy of different modalities, MRI, MR, arthrography, and ultrasound in the diagnosis of rotator cuff tears. And it was a meta-analysis comparing multiple articles that examined these different modalities. And here you can see this table looking at full thickness tears that they showed a similar sensitivity and specificity. But remember, this is for full thickness tears, not partial thickness tears. Now, of course, you probably at this point are saying, yeah, but the word that always comes up in any talk about ultrasound is that, isn't it operator dependent? Yes, but the counter to that is that it's really for full thickness tears. And if you're doubting, there's this paper, another meta-analysis that was done, and they concluded basically for full thickness tears that the accuracy is similar. Here's the table that's slightly confusing. The only one they gave was a combo of full and partial thickness tears, but they show something similar, that the sensitivity and specificity is similar. But the key here, yeah, so similar for the full thickness tear, and for partial, there's a high specificity, which means that you can rule in the diagnosis and you can find the tear, but it's difficult to rule out. You might miss the tear. But again, this is not our concern. It's really with these full thickness tears. And what they found here in the results is that whether you're a radiologist, a sonographer, or an orthopedist, that there's a similar sensitivity and specificity. So basically, the bottom line is that with some training, you can do it. Again, here they're looking at full thickness tears. All right. So the next thing about ultrasound, the advantage is that it can help address the situation with pacemakers, pacemaker MRIs. As you know, if you have a pacemaker, you can get an MRI, but they have to be monitored, at least at our institution, they have to be monitored by a cardiologist or somebody else who can adjust to the pacemaker or deal with emergency situations. Now, I don't know what the situation is at your institution, but at our institution, the waiting time is 6 to 9 months, which is crazy. I asked our service chief of MRI, and he said that there are 350 cases on the queue to be done with a pacemaker. So pacemaker monitoring. So, if you have ultrasound, you could bypass that and at least give the patient and the ordering physician the information that they need. Now, I had said that, for the most part, the pacemaker is not a problem because, here on this diagram, you see it's further medial in the chest, but we've also often seen where it can be a wide range of locations, but, and even over the more lateral aspect of the shoulder where it might get in the way. But in general, I think it's worth a try. Better than waiting 6 to 9 months for sure. But yeah, so think about that as sort of a quick way to answer some clinicians' questions. It's also cost effective, including post-operative. That same paper, they concluded that ultrasound is the best option for cost as well, but that's really just based on the standard or the cost of the ultrasound versus the MRI. It's not really a cost-effective analysis. There was this cost-effective analysis done for post-operative rotator cuff, published in AJR in 2022. And again, no significant difference between ultrasound and MRI looking for full thickness tears. Now, there is a caveat that this paper only focused on tears that went to surgery, which is the gold standard. So it's really biased towards full thickness and extensive re-tears. But again, those are the tears that we really care about. Patient mobility, of course, may limit the ultrasound examination. And that is because in general, to get the ideal examination, you need to have them in this modified CRAS position. Anybody who has tried an ultrasound on these patients, or even if you know somebody who has a rotator cuff tear, you know that this is a very difficult position for them to get in, even more so if they're post-op and they have limited mobility. But you can usually get away with patients putting their hands right on their hip or even just having their arm down on their side. And, there's one thing that I like about this is a sort of a side plug for ultrasound. I feel like it's one of the areas in diagnostic radiology that we really can still have some creativity, not so much in the image interpretation, but trying to problem solve and figure out how you can get the information that you need. So I like that about ultrasound. All right. And then also ultrasound is a, way that you can add in interventions into your practice as well. Because the shoulder structures are just very superficial, right? So you have the AC joint, you have the biceps tendon, you have the glenohumeral joint, that's a posterior approach, but all very superficial, all very easy to access, great for using ultrasound to do the procedure. Another one that we do commonly at our institution is doing Botox injections for thoracic outlet syndrome. And one of my favorite procedures of the shoulder is this condition. Give you a second to take a look at that. So this is a 50-year-old male with acute atraumatic pain, decreased range of motion. And here we see this amorphous cloud-like mineralization in the region of the rotator cuff and bursa, and this is calcific tendinopathy and bursitis. So for the trainees that are out there, this is when you have calcium hydroxyapatite deposition in the tendon and then eventually into the bursa, causing a lot of inflammation. The shoulder is your most common site. Apparently, the prevalence in the rotator cuff is 2.7% of the population, so not small. It's quite common to have calcium, but only about a third to a half of those actually had symptoms due to the calcium. And the phase of the disease really matters in terms of whether or not you can treat it with ultrasound. So just to go over these quickly, there's that pre-calcific or silent phase. And if they're visible, the deposits might not be visible, but if they are visible, they're well defined. And then this is the phase that we were just looking at in that radiograph called the calcific or resorptive phase. The hydroxyapatite starts to liquefy. It becomes that cloud-like, amorphous, having that fuzzy edge, and then it ruptures into the bursa, and then there's a lot of pain, acute pain. We had an orthopedic surgeon who actually had this condition and called us for help, and he described, literally it was fine, and then he woke up with severe pain, and the onset can be very sudden, and it can last for weeks, so it can be very, very debilitating. And then there's a post-calcific or adhesive phase. So, often a lot of my trainees will call calcific tendinopathy if they see any calcium in that area. And I say, whoa, we have to really look at the morphology and the shape, because if it's really in this post-calcific phase, they may or may not be symptomatic, and certainly we can't do as much for them. So it's important to consider that. So anyway, so this is the phase that we care about, and this is the phase that X-ray can identify well, that has fuzzier edges compared to this post-calcific and adhesive phase where you can see it looks much more solid. It's smaller and more homogeneous in its appearance. On the CT, actually, if they're dependent, you can sometimes see fluid levels. They're relatively large because the thing is enlarging and it's extending into the bursa. Mostly in the supra. And then really the X-ray and the clinical story can make the diagnosis. And sometimes if it's this big blobby thing, then the MRI doesn't really add a whole lot. It's just this low signal intensity blob in the bursitis. But when the calcium is really flocculent and small, it can actually be very hard to see it on the MRI. So I won't go again too much more into it because I think Dr. Islan will go into it more, but just remember that MRI doesn't always add a whole lot for this particular diagnosis. Okay, I'm sorry, I digressed, but it's important to address this because we're asking, how does ultrasound get involved here? Well, an optional next step after you make the diagnosis on X-ray would be to do a barbotage aspiration and corticosteroid injection. So take a look here. This is a sagittal image of the tendon. Here you see the deltoid muscle. It's actually not a lot of fluid in the bursa, but here you can see in the tendon, there's this cloud-like thing, just like you saw in the X-ray. You see posterior shadowing, and we know that there's shadowing because you see the cortex of the humeral head come here. It stops, basically. It doesn't stop. It's because we don't see it because there's shadowing from the calcium. So again, here's the amorphous cloud-like mineralization, the shadowing, and then you can do ultrasound-guided barbotage, and basically all it is sucking out that material, which is a lot like toothpaste. That's what it looks like when it comes out. And just like toothpaste, once it becomes that post-calcific phase, it becomes insipated and looks like toothpaste, the way toothpaste looks like when it sits on your bathroom sink. So it's really, again, only in that middle phase that you can aspirate. You got to inject corticosteroids and they improve very, very rapidly. It's very, very, I love this procedure because it does hurt them a lot when you do it, but afterwards they get so much better so quickly. It's just very satisfying. And really all these interventions in the shoulder are, I think, are very, very satisfying for something to consider. All right. So the yes, but is yes, you do have to do some training. But I'm going to convince you that you can do it. Not saying that it's easy, but again, we just have to diagnose the full thickness rotator cuff tear. So I'm going to give you some tips so that you can look quickly for the subacromial bursa and supraspinatus and things that you can try, maybe today when you go find an ultrasound machine. All right, so the key ultrasound trick that I want to mention is that it's important to look at the patient, focus on where your hands are and where the probe is, and not on the images to start. I'm not saying don't look at the images at all. It's just that if you get everything lined up here visually, then this will pop up into the screen. All right, just as a reminder, the subacromial subdeltoid bursa, what we're going to look for is the deltoid, under that, the bursa, which is imperceptible in a normal person, and then the cuff, and then the bone. So here you can see this is a scrolling image of the ultrasound. So here's the humeral head and the bone, here's the cuff, and here's the imperceptible bursa that's over the cuff, and then here's the deltoid muscle. The subacromial bursa, when I look for that, I just have the patient have their arm down, and that's the easiest way. And just have their arm in a neutral, like not internally or externally rotated. So really just sort of the relaxed position of the arm. Here is where you would expect the biceps tendon to be, and that's where I would place the probe and put it on, and this is what you would see. The shadowing of the acromion here. Here's the humeral head and the deltoid, the bursa, the cuff, and the bone. And this is also, I'm going to move a little more quickly because I'm running out of time, but this is how I would do basically the position you would do a subacromial injection, except that you would have them lie down. All right, so if we're looking for bursitis, again, in the normal person, it's imperceptible. You see some fluid, and in that little gap, and here's just other examples of that if you're going to look for that bursitis or have the bursitis. So I would just recommend that. Have the arm down, neutral, and go and try it out. All right, gearing up for the supraspinatus, now we have to talk a little bit about arm position. So I mentioned this modified CRASP position already, and it's really to bring the cuff from under the acromion. So you'll see on the pictures that are coming up that you don't see the acromion when it comes out, and you can see a lot more proximally in the cuff when you have them come out, but it's really not necessary, again, to address so this is where you would place the probe. I'm going to go through this quickly, but you can go back to these images because they'll be on the recording, and you can kind of line up the probe with your with the images. But this is what it would look like. So you can see that because the cuff is quite far forward, the probe is very, very far interior. I think that, a common mistake I see is people put it out here because they imagine it will be there. But when you position the arm in this way, you're not going to have the cuff it's going to be very far interior. I'm sorry. All right. So what if they can't put the patient's arm behind their back, which is very, very common, and they have the arm down? Well, just in the same position that you do the subacromial bursa, you can also evaluate the cuff there, but you can see that it's far, far more lateral. And here's just the comparison. All right. So thanks to Dr. Toriani, who would probably have a nightmare seeing all the gel on the other images, but he provided a lot of these schematics. And I'm just going to play this here for you. So you can see that here's the cuff coming over. Here is the greater tuberosity, and you can see the cuff coming smoothly over. And again, you don't see the acromion in these images because you've brought it out from under the cuff from the acromion by positioning in that modified CRASP position. All right, move ahead because we're running out of time. And here, so what are you expecting to see? Another thing is that when you have it in that stretched out position, you can see that the cuff should look convex, and that's going to be important when we look for a tear. So, when you have a tear, you just basically, a full thickness tear, remember that's what we're focusing on, you replace that whole cuff with fluid. So here's a 60-year-old female with chronic shoulder pain. We happen to have, luckily, their ultrasound and and MRI images, you can see that the fluid gap right there in the tendon. And then here the ultrasound image. So first we see that there is that same fluid gap there between the edges of the tendon. But the other thing that you see is that the deltoid is sinking into the defect, and that's called the deltoid indentation sign. Here we go. So instead of it being convex, you have it concave. There's the torn edge of the tendon, just like here. So you can see it's the same image. All right. And then on the sagittal image, very similarly. So here now, you're scanning back and forth. And again, you can see that it exactly resembles the sagittal image on the MRI. And you can evaluate for a tear in that dimension as well. And here you're looking, you actually, as you scan more centrally, you're going to see the cartilage interface as well. So let's see. Here we go. So here we see the full thickness retracted supraspinatus tear here between the different edges, that fluid gap in the middle on the MRI, and the same tear, you see the fluid gap between the center. We again see so the tendon, and then the fluid gap, and then we see that deltoid indentation sign. And in addition, we see here the cartilage interface sign, which is that double cortex sign. You see one cortex and a thinner second, more superficial cortex, and that's just from the ultrasound beam hitting the different changes in resistance. So the sound wave comes through and it switches from fluid to tissue to bone, and so you get that second echogenic interface. It's almost like an artifact, but we can use it to our advantage. All right, and so just as a final example of this cuff tear, so here's an 89-year-old female nurse who served in Africa for more than 20 years with persistent shoulder pain and weakness. So I'll give you a second to look at the image. So here's our acromion, here's our humeral head, we see our deltoid, and in the middle, we only see fluid, right? So we know that we have a full thickness rotator cuff tear. Really, at this point, if you've made it this far, you're done. But if you want to do a little bit more, you can turn sag, and you can see that that's probably the edge, maybe the deltoid or biceps. There's some debris. You can see there's not much cuff there. And then if you scan more posteriorly, you see that cuff comes back. Here's the edge of the torn tendon. So this is the full thickness tear, and this is the infra that's mostly still intact. The edge is a little bit irregular, but for the most part, you can tell them, they have a full thickness rotator cuff tear for sure. Probably it's just involving the supra, all that information, in just a few seconds. So I want to encourage you to try it out. This is clearly not a comprehensive ultrasound lecture. It's just to give you a taste and a few things to try, and maybe it'll convince you to investigate more. So yeah, find a friend, try different arm positions, look at the person, not, to find the direction of the rotator cuff or the orientation of where you're going to put your probe. Look for the subacromial bursa and the supraspinatus. All right, so this is my table for the things pro or against, and I just want to encourage you. I think ultrasound's really fun. Again, it gives you a lot of creative thinking. It's quick for a lot of these other things. You can do interventions, and it can be really helpful to add to a practice, in my opinion. All right, so I'm going to switch gears and do two shorter topics. First, quick topic number one, arthrogram. What does it really add? Also, in a practice, you might be in a situation where, I don't know, you feel like doing arthrograms, requires a lot of resources. Why am I doing these? Does it really add anything? In the shoulder, I would say I think it does. There are definitely situations where it helps. I think you should be selective. And also, if you don't have a fluoro unit, then you could do the injection or ultrasound just to combine the first section to this one. All right, so here's a paper where they discuss the Aber view, which I think is really the main thing that you get, the added benefit of doing the arthrogram. So the Aber view is the abduction external rotation. So imagine that you're sitting at the beach with your hand behind your head. That is the position in which is the Aber position. So it's the abduction, again, external rotation at the shoulder. So Aber, the key points, they said that it's useful for looking at the labrum. I agree. And they said it's not helpful with rotator cuff. I agree for the most part, but I'm going to show you some potential counter examples. And then it's helpful for the detection of slap tears. And then I agree with that. And then also it can be helpful. I think the one I would add is some cartilage defects that I see that this position can actually help to accentuate. All right, so let's look at some examples of this. So 17-year-old boy who dislocated his shoulder while playing basketball, and just take a look. Probably there's a labral tear here. You can see, so this is a T1 axial image. There's contrast that's been injected. Probably, right? There's a T1 line here going deep to the labrum. And then, you can see that the inferior capsule is very patulous. Probably there's been a Hagel as well. You use the axillary neurovascular bundle as the inferior margin for demarcating a really patulous capsule here. So there's probably both a Hagel and a anterior inferior labral tear. And here, so when you can try this on yourself, when you put your arm in that stretched position, the Aber position, you feel how that inferior capsule is really, really stretched. And we can see evidence of that here. So here's our labrum, and you can see that T1, the contrast separating the labrum from the edge of the glenoid better than when the arm is down. And then also you see the blind end of the inferior glenohumeral ligament, which is the torn end of the ligament from the Hagel. So there and there. And you can also see that the periosteum is intact, which is an important bit of information. You can tell that from here, but I think you can just see it better on the Aber. All right. How about this 18-year-old linebacker who redislocated the shoulder after a labral repair? And then here are the anchors in the anterior inferior labrum. So that makes sense with the prior labral repair. And you see all the cartilage loss. And, it looks like probably there's, again, the T1 there, probably tear, or is there some schmutz or something there? Well, here on the Aber view, again, with that inferior labrum, anterior inferior labrum stressed, you can see that contrast in that defect very, very well. So again, the Aber puts the tension on the labrum and you can see it. All right, so here and also on the same patient, you can see the superior labral tear with the arm up, but you can see it when you roll the humeral head back in that position. It also stresses the superior labrum because this here is pushing on that edge, especially when they're lying down. Not so much when you're sitting up, but the gravity is pulling that humeral head and pushing on that superior labrum. So sometimes you can see rolling back of that labrum and stress on there better when you have the arm in that position. All right, and then the question is there a rotator cuff tear here in the infraspinatus in the, we see that there's some increased T1 signal in the cuff, right? We should not be seeing that on if there is not a tear. So already we suspect that there's an undersurface tear, but when you put that arm in that position again, you relax that undersurface of the cuff and you just see that contrast just flow into the defect. So again, I think you can make the diagnosis with the arm down, but having it in that Aber position really adds a lot. All right, only 18, kind of stinks he has so many things. All right, so here's a 53-year-old man who had pain since a direct fall on his shoulder while skiing. And this one, I'm going to go more quickly again. We don't see any tear here, but when the arm back, the infraspinatus, we now see that there's contrast in the tear. He also happens to have a tear here of the posterior superior labrum. So, I don't think this is an acute issue, but this is basically what you'd be looking for as internal impingement in throwing and overhead athletes. That's, again, not his acute issue, but maybe in his past life he was a thrower. I thought that was a good example of the combination of those findings. And in some people, you can actually demonstrate the internal impingement. So this is a paper where they showed the poor 17-year-old girl. They actually imaged her in this position. It must have been really painful. But yeah, anyway, so I think the Aber can add a lot and give you a lot of information. All right, and I think this is the final case I have on this. So a 17-year-old volleyball player with insidious onset shoulder pain with clicking and popping. You can see, again, the cartilage flap when they have their arm down. But when they put it in the Aber position, you're stressing the joint too. You can feel tension on your joint. And when you have that, it's almost like a suction, it lifts up the cartilage defect a little and you can just see it a little bit better. All right. So AVER caveats. Right. Here you can see this is the technician's note about this position. They try so often because they have instability or they have pain, they can't hold that position. That's why that patient, that 17-year-old patient who had internal impingement, it's amazing. She had that pristine image without any motion. So, and sometimes they can't get up. The arm should be much higher up, probably in this angle over here, but it's all the way down. That leads to some creative plane acquisitions. And this is me scrolling through that AVER image. I mean, you can see there's so much motion, it pretty much renders it useless. So that's really the caveat for the AVER, is that position often causes them a lot of pain and they're not really able to tolerate it. And if that's the case, then I guess it doesn't really add anything at all. All right, so arthrogram, I think it can be really helpful for these things. Again, if you have you could even add it to easily to any clinic where you have space just for an ultrasound machine. You can inject the contrast that way. And I think in these particular situations, if you're looking for these things in younger people and athletes, it can really add something. All right, and just another quick topic, number 2, of things that are sort of coming down the pike. So ZT, or zero echo time, or ZT, ZET MRI, is a CT-like sequence, and it basically takes advantage of the ultra short T2 relaxation times of dense tissues like bone. And it's really a work in progress. I mean, we've tried to add this on because obviously orthopods want it. A lot of the people who get this sequence or need this sequence for preoperative planning are young people who, you'd rather not do an additional CT on them if you don't want to. But at this point, I still feel, for the most part, or at least at our institution, and the spatial resonance still not as good. And there are other definite pitfalls like calcification, mineralization, and susceptibility artifact. So here's a pristine example they show from this radiographics paper, where you can see the little tiny, avulsion on the anterior inferior glenoid. But I think this is something that's coming down the pike, definitely something to consider that would improve patient care, especially for young patients. But overall, yeah, I think it still needs some work. So that is all I've got. Thank you so much for listening.